Hello, everyone. We are right at the 1:30 mark, so we are going to go ahead and get started with today's webinar. Thank you for joining us. My name is Jessica Bador, and I work with APTO as their Workforce and Communications Coordinator. And with winter just around the corner, we know winter is norovirus season, so now is the perfect time to start getting prepared. We're excited to have you join us as we hear from federal, state, and academic subject matter experts in today's webinar. Our experts will be taking a deep dive into prevention and investigation of this highly contagious virus, including norovirus illness and outbreak surveillance, best practices for norovirus prevention and outbreak investigation, as well as best approaches for interviewing retail establishment employees during an active norovirus outbreak investigation. Next slide, please, Amy. Today's presenters will be Dr. Sarah Mirza, who has been an epidemiologist with CDC for nearly 20 years, currently serving as the Epidemiology Deputy Team Lead, leading norovirus epidemiology programs in the Viral Gastroenteritis Branch, Division of Viral Diseases, at the National Center for Immunizations and Respiratory Diseases. She has served in many roles at the CDC, gaining significant expertise in establishing and evaluating surveillance systems and program management. She has also worked extensively on global health security issues and in building capacity for laboratory and pandemic preparedness in multiple countries. She earned her MPH from UCLA in epidemiology and biostatistics and her PhD in epidemiology from Johns Hopkins University, Bloomberg School of Public Health. Anita Kambhampati is an epidemiologist in the Viral Gastroenteritis Epidemiology team with the CDC, also at the National Center for Immunization and Respiratory Diseases. Her work there focuses on epidemiology, surveillance, and prevention of norovirus. She holds a Master of Public Health degree from the Rollins School of Public Health at Emory University. Beth Whitry serves as a food safety subject matter expert for the CDC's National Environmental Health Division of Environmental Health Science and Practice. In this role, she oversees food safety research projects to understand environmental factors associated with foodborne illnesses and outbreaks in order to advance science-based prevention and intervention recommendations, enhance outbreak investigation practices, and help inform national food safety policies. DJ Irving worked as an environmentalist for 5 years with the Metro Public Health Department in Nashville, Tennessee, before joining the Tennessee Department of Health in the Foodborne program in 2016. At TDH, he is responsible for the implementation of the National Environmental Assessment Reporting System, or NEARS, where he provides foodborne outbreak support and performs food safety research. He has an MPH in epidemiology from Eastern Tennessee State University and is a registered environmental health specialist. Martin Weidman received a veterinary degree and a doctorate in veterinary medicine from the Ludwig Maximilians University in Munich and has a PhD in food science from Cornell, where he is currently the Gellert Family Professor of Food Safety. His research interests focus on farm-to-table microbial food quality and food safety, and the application of molecular tools to study the transmission of foodborne pathogens and spoilage organisms, including translation of the associated research findings into reducing foodborne illnesses and food spoilage. His team has published more than 400 peer-reviewed publications, which have been cited more than 20,000 times. And he and his team are also regularly asked to help industry with a range of microbial food safety and quality challenges. So we have a great group to present to you today. Before I turn the panel over, I want to just encourage all of you in the audience to keep track of your questions. You can enter them into the chat box at any point in time, but we will hold the questions until the end. So if your question is for a specific speaker, please note that with your question in the chat box. And Dr. Mirza, the floor is now yours. Thanks.
Thanks very much, Jessica, and thanks to everyone for joining us today. As Jessica mentioned, I'm an epidemiologist with the Viral Gastroenteritis Branch at CDC, where we focus on understanding trends and patterns in norovirus disease, both outbreaks and sporadic cases. Anita and I work on the epidemiology side, and we have an entire laboratory that works on better understanding what different subtypes are circulating for norovirus with Dr. Jan Vignier in his lab. So to better understand the epidemiology of norovirus throughout the United States and actually globally as well, we've established various surveillance systems. And to start us off today, Anita will be sharing an overview of norovirus epidemiology and the surveillance systems that we use. And she'll also share some recent data that looks at the impact of the COVID pandemic on norovirus outbreaks. And we hope that this overview helps us best inform practices to prevent foodborne norovirus outbreaks. So we look forward to the discussion and your feedback. Thank you. And with that, I'll pass it to Anita.
Thanks so much, Sarah. Hi, everyone. My name is Anita Kamampati, and I'll be talking about norovirus epidemiology and surveillance. And we can go to the next slide, please. So for those who are not as familiar, norovirus is quite notorious. It's the leading cause of acute gastroenteritis outbreaks across all age groups, and often makes an appearance in our headlines, as you can see here. And so we'll go to the next slide, please. So to start off with some background on the pathogen and why it's so easily spread. Norovirus transmission can occur in a number of ways, including direct person-to-person contact, consumption of contaminated food or water, and contact with environmental surfaces that have been contaminated with the virus. Next slide, please. Noroviruses have an incubation period of about 12 to 48 hours, after which infected individuals will generally suffer from sudden onset vomiting and or diarrhea. Excuse me. Most people will generally recover within about 3 days, but about 10 to 12% of people will seek medical assistance. And some people, particularly young children, older adults, and those who are immunocompromised, may experience more severe illness. And about a third of illnesses are subclinical, so people may experience very mild or no symptoms at all, which can be important for transmission of the pathogen. Next slide, please. So once an individual is infected, viral particles are shed copiously in both stool and vomit, in the order of 100,000 to 100 billion viral copies per gram of feces. Shedding can occur for several weeks, including after symptoms end, and the virus can survive on surfaces and is resistant to many disinfectants. This all coupled with the fact that it takes very little virus to make an individual sick, as few as 18 viral particles, or as few as can fit on this pinhead pictured here. It means that norovirus is very well adapted for transmission. Next slide, please. So CDC collects outbreak investigation data through a few different systems. When we think about norovirus outbreak surveillance in terms of the epidemiologic triangle shown here, epidemiologic data on the host or the population affected by the illness are reported to NORS, the National Outbreak Reporting System, by state, local, and territorial health departments. Molecular data on the agent causing the illness, norovirus in this case, are reported to Calicinet. And then we have facility level environmental assessment data from foodborne outbreak investigations, and these are reported to NEARS, the National Environmental Assessment Reporting System. So taken together, the data from these systems can be linked. And again, taken together, these data provide a comprehensive and robust picture of norovirus outbreaks in the United States. So for the remainder of this presentation, I'll primarily be focusing on data collected by NORS and Calicinet. Next slide, please. So I'm going to start off by talking about seasonal trends in norovirus, since the norovirus season is almost upon us. So we're able to assess these seasonal trends in near real time through Norostat, our sentinel surveillance system. Reporting to NORS, the National Outbreak Reporting System, is voluntary, so states can report outbreaks that occurred at any time. But since our program specifically is interested in keeping our finger on the pulse of norovirus, in 2012, we implemented Norostat, the Norovirus Sentinel Testing and Tracking Network. We currently have 12 states that participate in Norostat, and these states are required to report norovirus outbreaks to NORS and Calicinet within 7 business days of health department notification. And they're also required to report a minimum set of required data elements. So this allows us to track in near real time how the norovirus season is going. We can look at trends and then assess any impacts of emergent strains. And we can go to the next slide, please. So this was really important over the past year and a half when health departments became very busy with COVID activities. And we, on the epi side, weren't quite sure what would happen with norovirus transmission. So through Norostat, we were able to remain aware of reported norovirus outbreaks. As you can see here in this figure, the gray area represents our range of reported outbreaks from 2012 through July 2019. The green dashed line represents outbreaks reported from August 2019 through July 2020. And then the red line represents the last surveillance year, which went from August 2020 through July 2021. And from August 1st, 2020 through July 31st of this year, there were 343 norovirus outbreaks reported by Norostat participating states. During the same period from 2019 through 2020, there were 1,056 norovirus outbreaks reported by these states. You can see in early March of 2020, we noticed that the number of reported norovirus outbreaks really plummeted. And we'll go to the next slide, please. So we really wanted to look into why this occurred. One potential explanation was underreporting, that we perhaps were not receiving outbreak reports from states that were busy with other activities with COVID response. But since our Norostat states are required to report all outbreaks, and they anecdotally indicated they were still doing so, we knew that this was less likely to be the primary driver. We also considered seasonality. So as we discussed a little, norovirus outbreaks do occur year round, but we generally see a wintertime peak from around December to March. So the factor as well. But our primary hypothesis was that widespread non-pharmaceutical interventions, NPI, if you will, for COVID, such as social distancing, mask wearing, facility closures, surface disinfection, and increased hand hygiene were impacting norovirus outbreak incidents. Next slide, please. So we analyzed data from the 9 longest Norostat participants and found a statistically significant decline in norovirus outbreaks from April through July of 2020, following the start of NPI implementation. We saw this even after accounting for seasonal patterns. We observed this decline across all included states and all settings. We also compared outbreak sizes and found that, as you can see in this figure, smaller outbreaks were reported across all settings in comparison to the same time frame in previous years. So this indicates to us that underreporting or preferential reporting of larger outbreaks was less likely to be the primary driver. Next slide, please. So one caveat to our analysis is that it's really difficult to parse out individual effects of the various NPIs on the reduction in incidence. And this figure here is a more recent version of the previous figure. And as you can see here with the green dashed, the green dashed line and then the red line, which represents this year, that norovirus outbreak activity picked back up around April of this year. And we're continuing to monitor reported norovirus outbreaks, especially as we're moving into what we think of as our season. But since we're not really sure what the coming months will bring, it's really important to continue adhering to general norovirus prevention measures in order to keep transmission lower, as well as reduce any potential impact on the system. Next slide, please. So now we'll talk a little bit more about the epidemiology of norovirus outbreaks and how we use these data to inform our prevention guidelines. We recently looked at 11 years of outbreak data reported to NORS from 2009 through 2019. As I mentioned, NORS collects data on all foodborne, waterborne, and enteric disease outbreaks. And among over 38,000 such outbreaks reported, norovirus was the most commonly reported etiology and represented 59% of reported outbreaks. And so here we've shown the norovirus outbreaks by setting. Of over 22,000 outbreaks reported during this time period, the most common setting was long-term care facilities, followed by schools and daycares, and then restaurants. Next slide, please. So we also looked at the mode of transmission, or how these outbreaks were spread. The vast majority of norovirus outbreaks were spread through person-to-person transmission and then followed by food. Other modes of transmission accounted for a smaller proportion of outbreaks, But for the purposes of this webinar, I'll mainly focus on foodborne transmission. Next slide, please. So norovirus is the leading cause of foodborne illness, as well as foodborne outbreaks in the United States. From 2009 to 2012, it accounted for almost half of foodborne illness outbreaks with a single known cause. It's also one of the leading causes of foodborne hospitalizations and deaths, and costs approximately $2 billion annually in healthcare expenses and productivity losses. Next slide, please. So a few years ago, we examined approximately 500 foodborne norovirus outbreaks that occurred from August 2009 through July 2015, and were reported to both NORS and CaliciNet. Food products were implicated in about a third of these outbreaks, with specific implicated food items listed in the figure on the right. The red bars represent G2.4 norovirus, which is the most frequently reported genotype, and the blue bars represent non-G2.4 noroviruses. And here you can see that vegetable row crops, fruits, and molluscan shellfish were most implicated. We also found that food workers were implicated in about 76% of outbreaks with contributing factors. And bare hand contact with ready-to-eat food was specifically implicated in over half of those outbreaks. Next slide, please. So these findings really reinforce the need for improved compliance with CDC guidelines, as well as underscoring the provisions in the FDA Model Food Code. And specifically, these recommendations include practicing proper hand washing and minimizing bare hand contact with ready-to-eat foods, having certified kitchen managers and training food service workers in food safety, and excluding ill staff both during and shortly after symptoms end in order to address post-symptomatic shedding. Next slide, please. So again, these recommendations are outlined in the Food Code, which is published by FDA and updated every 4 years. Adoption of the Food Code in whole or in part is at the discretion of state and local governments. But given how important these recommendations are for prevention of foodborne illness, we wanted to assess state-specific adoption of 5 provisions specifically identified to prevent norovirus. And again, this is the requirement for hand washing, prevention of bare hand contact with ready-to-eat food, exclusion of staff ill with vomiting and diarrhea, so not just norovirus, until at least 24 hours after symptoms end, requirement for a certified food protection manager, and a response plan for contamination events such as public vomiting. So to do this, we compared the food codes of all 50 states and DC to the 2013 FDA Food Code, which was the most current version at the time of the analysis. Next slide, please. So here we show the states that adopted each provision shaded in blue. All jurisdictions had adopted in some form the hand washing provision, but as you can see here, there was substantial variation in adoption of the other provisions at the time of the analysis. We'll go to the next slide, please. So we then looked at associations between state adoption of these provisions and almost 1,500 foodborne norovirus outbreaks reported to NORS between 2009 and 2014. So this figure shows the reporting rate of foodborne norovirus outbreaks among states that did adopt the provisions, represented in the blue box, and those that did not, represented by the red box. So we found lower rates of reported foodborne norovirus outbreaks in states that adopted these provisions compared to those that did not. And this suggests a potential impact of adoption on reducing incidence of foodborne norovirus. Of course, as with any analysis, there are some limitations. So among others, we were only able to assess adoption on a state level. There might be additional regulations at the county or local levels, or even on the individual restaurant level. And we were not able to assess compliance with adopted regulations, but the work of our colleagues in NEARS has really helped us do this. And next slide, please. So I will just wrap up. Noroviruses are the leading cause of AGE outbreaks and foodborne disease in the United States. We see that infected food workers are the most common source of foodborne norovirus outbreaks, and often due to bare hand contact with ready-to-eat food. We're continuing to monitor norovirus activity and further understand the impacts of the COVID-19 pandemic and various mitigation measures on norovirus. And in the meantime, it's important to continue to adhere to the recommended norovirus prevention guidelines in order to improve food safety in the United States. And with, I'll pass it off to my colleagues in NCEH, and we can go to the next slide just for some acknowledgements. And thank you so much for the opportunity to present.
All right, good afternoon and good morning to some of you. My name is Beth Witchery, and Anita and Sarah really set the stage for this presentation. So I will be discussing on how to prevent norovirus outbreaks and sick food workers by leveraging environmental health data into practice. Okay, so shown here is a schematic of a food establishment. And as we all are aware, these are complex systems from receipt to service of food. And at any point in this continuum of the food flow, there may be a breakdown of food safety and a potential for the introduction of pathogens. So as a reminder, an environmental assessment is a systematic process designed to gather as much information as possible to describe the food safety failures in the environment. And this approach can be applied during an inspection or an outbreak investigation. But in the context of an outbreak, these assessments help identify the underlying environmental causes of foodborne illness outbreaks. So if you look in the center of our schematic, we have some variables that include people, equipment, processes, foods, and economics. And these variables can exert both positive and negative influences on food safety and food establishments. To give you an example, a manager who ensures workers care about food safety would be a positive people influence, while a manager that doesn't train workers on food safety would be a negative people influence. And as environmental health specialists, we must assess all the inputs and outputs of the system and understand how these variables influence the system. So if we understand the interplay of variables on food safety, then we can implement and recommend sustainable control measures and prevent food safety failures. So I will present this schematic later using an outbreak example, so keep all of this in mind. So first, let's look at some national foodborne outbreak data, as this can help focus our resources to where they are needed. So restaurants are the most common single setting outbreak location. And because most US foodborne disease outbreaks are linked with these type of establishments, most of the data I will present today is focused on retail food establishments. Norovirus is also the most common restaurant outbreak pathogen. So it causes 46% of outbreaks and 42% of illnesses. And you can see other pathogens that were responsible for restaurant outbreaks on this slide. And we have also at CDC data from the outbreak investigations that tell us the most common factors that contribute to outbreaks in restaurants. So almost half, or 47% of outbreaks with identified contributing factors are associated with a worker who is determined or suspected to be infectious. Again, these data show us where we can focus our prevention efforts. So prevention of the outbreak contributing factors really are key. And what we know, and as Anita highlighted, infectious workers contaminate food and the environment. And our prevention measures really underscore provisions in the FDA food code as well as CDC guidelines. And to emphasize the points that Anita made, what we need to do is establish policies that require food service workers to stay home when sick with vomiting and diarrhea. We also need to practice proper hand washing and use utensils and single-use disposable gloves to avoid touching ready-to-eat foods with bare hands. And we also need to clean and sanitize our food contact as well as our non-food contact surfaces. So now I'll show how CDC has leveraged their food safety research as well as their norovirus outbreak data to influence national policies and guidelines. A recent publication with NIRS data showed that norovirus outbreaks were smaller and shorter when restaurants had certain practices. We found norovirus outbreaks had fewer sick people when restaurants provided training on food safety. And this research suggests that restaurants can reduce the impact of outbreaks through the following actions: providing food safety training for managers and food workers, having managers certified in food safety, and having cleaning policy for surfaces where food is prepared. We have also conducted research to understand why workers work while sick in order to recommend sustainable solutions. I think most of us suspect that it's for economic reasons, and that's true. The top reason workers gave for working when sick was the restaurant did not offer paid sick leave or have a sick leave policy. So you can see on the left, that's why workers reported they worked while sick. And to the right is why managers reported they worked while sick. And so these other common reasons for workers and managers were the restaurant was shorthanded and no one else could take their shift. They did not feel very sick or thought they would not pass their illness to anyone else. And their sense of duty or strong work ethic. So what this research suggests is we need to apply a multi-layered approach when developing prevention strategies to ensure workers do not work while ill. So this not only includes having an employee health policy, but also ensuring our staff are trained and also having adequate staff management plans. So our research findings have been published in multiple journals and disseminated at numerous conferences to inform and advance the food safety practice. But our research has also informed provisions in the 2013 and 2017 FDA food codes around certified kitchen managers. CDC found that restaurants with foodborne outbreaks were less likely to have a kitchen manager certified in food safety than restaurants without outbreaks. So as a result, the 2017 FDA food code now requires managers, it requires restaurants to have certified managers on site during all hours of operation. And our research, as well as FDA's research from the risk factor studies, show that we need to support strong food safety management systems. So this means having policies and procedures, training and certifications, as well as monitoring and validation to have fewer unsafe food practices. And for norovirus prevention, we really need to use a multifaceted approach to prevent and control norovirus in restaurants. And finally, let's discuss incorporating root cause analyses or environmental assessment into inspections. So I'll present some outbreak root cause data from norovirus outbreaks, and we can apply the lessons learned to change and inform routine inspections, trainings, and practices. So here again, I'm showing that restaurant system schematic. As an investigator, must assess all the inputs and outputs of the systems and really understand how these variables, people, processes, equipments, food, and economics might influence this food system. So if they have a negative influence on the system and contributed to the food safety failure, these conditions are referred to the environmental antecedents of the outbreak. So let's walk through a quick norovirus outbreak example. So during an outbreak investigation, we're trying to determine what happened, how it happened, and why it happened. So this investigator determined that there was norovirus contamination at a preparation step, and it happened by bare hand contact from a sick food worker handling ready-to-eat foods. And why it happened, that takes additional work and insight, as investigators must ask probing questions to our managers as well as our food workers to determine the role that these variables might play on the food system. So why it happened, the manager and food worker tell us there was no training and the manager was not enforcing the employee health policy. So one people antecedent might be due to the lack of training and oversight. The food worker that reported that they were working while sick also reported that economics played a factor in their decision to go to work, as there was no sick leave and they needed a paid check in order to support their lifestyle and live their life. So understanding the why or the root causes or the environmental antecedents helps us stop current outbreaks and prevent future ones. So let's look at some NIRS environmental antecedent data. And this data component was added in the 2017 NIRS instrument. But I would like to mention that environmental antecedent data is based on the investigators' perceptions and thoughts based on this investigation. So right now I'm showing you 3 years of NIRS data for norovirus outbreaks. And we can use these data to identify and inform really our long-term solutions to prevent future outbreaks. And many of the prevention strategies rely on outside of the box thinking as they fall outside the scope of the food code, but offer sustainable control measures to prevent workers from working while sick. So you can see the top common antecedent that was identified during norovirus outbreaks relates to people, followed by process and economics. So I will discuss each of these in more detail. So the people antecedents that were reported for norovirus outbreaks include lack of oversight of employees or enforcement of policies, lack of training on specific processes, and lack of a food safety culture attitude towards food safety. Another top people antecedents included low and insufficient staffing, which I'm sure we can all relate to right now during the pandemic. But thinking about long-term solutions, we should be operationalizing, verifying, and validating employee health policies. It's more than just having an employee health policy, but understanding if it's feasible for the operation and understanding it before an outbreak occurs and we have sick workers working. In addition, we need to train food workers on our employee health policy and really incorporate plain language or incorporate trainings that are in their language. We have very diverse food worker populations. So in order to really help them understand the public health reasoning behind why we need to report our illness and not go to work when we have vomiting and diarrhea, we want them to understand the why behind the what. So understanding that we can get people sick if we come to work with vomiting and diarrhea will really resonate with the workers. And finally, and I think the most important long-term solution is empowering managers to create a safe, healthy environment. Our onus should be on the management to create that environment that encourages and supports sick workers from staying home. I think a lot of us place the onus on the food worker, but they might not report because of different fears of losing their job, losing pay, being punished. So putting onus on the management means a variety of things. The management makes it clear that workers should not work while sick, and the management works to make sure workers don't work while sick. So this means management has clear sick worker policies. They have good staffing plans so that if they run to a situation where the worker is sick, the establishment can still operate without them. The workers also aren't punished for calling in sick with loss of pay or shifts. And ultimately, management ensures the food workers are trained. So other common antecedents include process antecedents. And investigators reported employees or managers not following the facility's process. So really understanding how do you make the process easier, or why are people not even following the process? So some establishments, what they've done for long-term solutions is implement health screens prior to work shifts. So asking if workers have had vomiting and diarrhea within 24 to 48 hours, so they can exclude them right on site, but also incorporating reminders into the operation about not working while sick. We need to make daily efforts to drive the message home that workers shouldn't work while sick. And what is the process if they do feel sick? It's not enough just training them once, but really having them understand, if I have vomiting and diarrhea, what do I need to do? I need to report my symptoms to the manager so they know I should be excluded from the operation. And then finally, the economic antecedents are reported or lack of sick leave or other financial incentives to adhere to good practices. And these antecedents are the most difficult to assess, but very necessary to understand if we want workers to stay home when they're feeling while sick. So some long-term solutions include offering makeup shifts for sick time, providing an on-call list or, staff management plan. So we can support that worker and they don't feel that they are leaving their fellow workers short-staffed, and providing sick leave, either paid or unpaid. So in conclusion, our current research shows that we need to support strong food safety management systems in restaurants. So again, this includes our policies and procedures, our worker and manager training and certification, and monitoring and verification. And our data again show us outbreak investigations that prevention of norovirus should be a priority. And so we should focus on preventing workers from working while sick, prohibiting bare hand contact, and requiring certified food protection managers. And finally, we need to invigorate and incorporate root cause analyses into inspections to address the underlying environmental causes of norovirus outbreaks. As we saw, many of these underlying causes are due to people variables. So these actions will support the prevention of future outbreaks. All right, and I will turn it over to my colleague, DJ.
Everybody, can you hear me okay, Beth?
Yes, we can.
Great. I will get going here. All right, and can you see my screen? Is you, Beth, can you see my screen okay?
Yes, thank you, DJ.
Great. And for some reason, my video is not sharing, so you may not be able to see my face. I know a lot of you might be upset with that. There we go. All right. So first of all, it's great to be here with everybody today, and such a wonderful panel and talking about norovirus, one of my favorite bugs. We haven't had a lot of norovirus excitement in the past couple of years, and we missed doing a lot of these outbreak investigations, but kind of dovetailing off of what Beth was discussing earlier, I'm going to kind of dive down deep into the process of conducting a norovirus outbreak investigation at retail food service establishments. Again, my name is DJ Irving, and I work in our Foodborne program at the Tennessee Department of Health. All right, so what I'm going to cover today, just a brief outline here, is who should be on your outbreak investigation team, or at least how our outbreak investigation team is organized, how outbreaks are notified. So are you notified through a complaint system or through some type of pathogen surveillance? Developing hypotheses when you have available information on cases, symptoms, and possible food exposures. going to provide you with some interview questions that we like to ask during suspect norovirus outbreak investigations. And then I'm going to walk you through a outbreak example that we had in 2019, and then cover some effective control measures depending on the type of norovirus outbreak investigation you may be working. So I think we all know this. Outbreaks take a number of professionals to be able to successfully investigate them, from environmentalists to epidemiologists, laboratorians, public health nurses, and information officers for media requests or distribution of media. And right now I'm going to focus primarily on who the environmental health specialist team should be when conducting an environmental assessment. So I think states all approach this a little bit differently. Some areas may send in a routine inspector, some may send in their survivor or supervisor, or a specially trained outbreak investigator. And then here in Tennessee, we kind of do a hybrid of this. And just to give you an idea, a quick idea of our layout, we're broken out into 8 different health regions with 5 contract counties. You'll see in gray there. Those contract counties are large metropolitan areas. And we serve a population of about 6.9 million people with 28,000 food service establishments and have approximately 170 environmental health specialists. Now, we're lucky enough in Tennessee that we have 2 environmental health specialist network CDC resources in Davidson County, Nashville, Tennessee, and in Knox County, Knoxville, Tennessee. And our role is to do the work of the Environmental Health Specialist Network food safety studies, both our own site studies and multi-site studies, but also to enhance our training to our staff on conducting environmental assessments and to provide support, varying levels of support during foodborne illness outbreak investigation. So the 2 SNET resources will either during a foodborne illness outbreak, at minimum, we provide consultation to the managers or the inspectors in those regions on what they should be looking for during an outbreak, or just there on call to answer any questions that they might have. Or we will provide boots on the ground support. And depending on the experience or the outbreak scenario, our field office managers across the state may ask that we accompany them during foodborne illness outbreak investigations and provide our expertise, and also just to be an extra set of eyes in the field. We never send environmentalists by themselves to a restaurant to conduct an assessment. Anybody that's worked one of these investigations or has done even routine inspection work knows that restaurants are dynamic environments. There's a lot going on with, like Beth was pointing out, with the people there and their equipment, and then outbreaks especially can be very intense situations and highly stressful for the owners. So having a team go out with a varying level of expertise is really important, so you can do an effective assessment and really get to those contributing factors and environmental antecedents that Beth was talking about. In addition, we also provide sampling support. So if the decision's made to conduct any environmental sampling, surface swabbing, or food collection, we house in those 2 SNET sites in Knoxville and Nashville all of our environmental sampling supplies. So we're able to send out those supplies or take them with us on site to an investigation. And Danny in the Eastern Tennessee, Knoxville part generally covers some of that Upper Cumberland area, and then the rest of the East and Northeast Tennessee. And then I'll cover this Middle Tennessee region all the way out to West Tennessee. And between Danny and I, we can really get to any one of these counties within about a 2 to 3 hour drive. So we're ready to go at any time and can provide that boots on the ground support and sampling support if needed. So I'm going to draw some very general distinctions today between norovirus outbreak investigation and a salmonella outbreak investigation, and just try to highlight some commonalities. Now, these things don't always apply to every outbreak scenario, and we know there's always exceptions to the rule, but in general, for norovirus outbreaks, we find out about these through our centralized complaint system. The system is very helpful in identifying norovirus outbreaks because of their quick incubation period. But the system can also have a lot of noise in it. Anybody that's managed or taken foodborne illness complaints knows that folks generally report the last meal that they ate, and it takes a really good interviewer to dig deeper and get a meal history from that individual. What's nice about the complaint system is that we can usually have boots on the ground within a relatively short period of time from when that actual exposure occurred, increasing the likelihood of us capturing those contributing factors and the events that took place in that restaurant that contributed to the outbreak. Now, with pathogen surveillance, taking Salmonella, for example, if we identify an outbreak through pathogen surveillance, we have a high level of knowledge about what bug it is that we're dealing with, and depending on the interviews that were conducted with the cases, the people infected with Salmonella, we may have a really good idea of the restaurant location, the suspected similar exposure, and the foods that they ate. So we'll have quite a bit of knowledge going into that facility about this individual's exposures, but we're generally going to be in that facility long after their exposure, anywhere from 30 days or more. So a lot can happen in the restaurant in 30 days, and the events that took place that day may not be there. Again, just really emphasizing the importance of having good interview skills and a plan going in to conduct these assessments. There's a number of tools that we use before we ever step foot into a facility to try to generate some hypotheses about what pathogen we're dealing with and some things we may want to look at in the facility, especially if we don't have great food history and don't know the pathogen. I just wanted to highlight this tool. I go to this link all the time when we're looking at outbreaks to try to make hypotheses about possible pathogens that we're dealing with. It's a CDC web page on the guide to confirming an etiology of foodborne disease outbreaks. And this is really helpful in generating some of those pathogen hypotheses. I'm just going to highlight Salmonella here. So for non-typhoidal Salmonella, we see that the incubation period is usually 6 to 48 hours with diarrhea reported, and often the individual having fever and abdominal cramps. Whereas with norovirus, we see a median incubation period of 33 hours with diarrhea, vomiting, nausea, abdominal cramps, and possibly a low-grade fever. So there's some general rules of thumb out there with if you're dealing with a batch of cases, and if over 50% of them are reporting vomiting, you're probably not likely dealing with the Salmonella outbreak, and it could be norovirus that you're dealing with. But again, when you have such limited information, you want to use these tools to help guide you, but also not get tunnel vision and go, yep, this is definitely norovirus. Earlier, Anita was pointing out too, just the seasonality of things. That's also a consideration that we take. If we're in that peak norovirus season, the January, the wintertime frame, and we're getting these diarrhea, vomiting episodes in people that are having fairly quick recovery times. Generally, with Salmonella, the recovery time is going to be a lot longer, whereas with norovirus, we're usually looking at 1 to 2 days. And Salmonella, we see more Salmonella in general in the summer months. So that's something that we also take into consideration when developing these hypotheses. So just like how there's that relationship with the pathogen and its host and the symptoms that the hosts are displaying, and the hypotheses you can generate just from a symptom profile, There's also these common relationships between the causative agent, and there's common relationships with the foods that they're associated with, and with the contributing factors or the events that took place in the restaurant that led to the contamination, proliferation, or survival event. So with Salmonella, I think any of us know here, when we hear Salmonella, we immediately think poultry, and that's not just a random thing. Salmonella is commonly associated with these bugs. And during a restaurant outbreak investigation, we may find that there's also tools out there that show these pathogens have common associations with people's behavior in the restaurant. So for Salmonella, it's not uncommon to identify a contributing factor that is cross-contamination, where an individual is preparing raw chicken or eggs in a bowl or on a cutting board, and they're not properly sanitizing that equipment, and then using that same cutting board to chop lettuce or tomatoes or ready-to-eat foods that aren't going to go through a cook-kill step. Also with Salmonella, we see a contributing factor a lot in our investigations here of survival. So, we have a lot of restaurants here that are, trying to make everything from scratch. So they're small independent restaurants, and we've had a number of egg outbreaks where we get into the firm and we identify that they're making some type of aioli sauce or a hollandaise sauce, or using raw eggs in their material, and that product is not going through a proper kill step, and the eggs were contaminated with Salmonella. So there's a survival issue there. And then, I'm going to kind of reiterate this as we walk through. Just the whole reason that we're in these firms is to try to get control measures in place, and control measures for Salmonella outbreak, I'll highlight here, may vary quite a bit from control measures you put in place for a norovirus outbreak. So with norovirus, sometimes we may or may not have a food. Norovirus isn't commonly associated with foods. We've seen some berry and shellfish, oyster type outbreaks with contaminated waters, but a lot of times, norovirus makes epi investigations and implicating food sometimes impossible, because the food handler, depending on what they do in that restaurant, they may have one very specific task. If they're contaminated with norovirus and working while ill, and they are only in the salad station prepping salads, and they're not touching anything else in the restaurant, we may get an epi signal from that investigation. But if the ill food handler is doing a number of different tasks and jobs in the restaurant, preparing all different types of foods, it's not uncommon that we will not get any type of implicated food in this outbreak, because the virus has contaminated multiple food items. So again, control measures here, a lot of times, like with Salmonella, maybe deal more with the restaurant's processes, not having a kill step, serving raw animal products, or some type of cross-contamination event. Whereas with norovirus outbreaks, the majority of the ones that we investigate, we can trace back to an ill food handler, as highlighted by Beth earlier. So those control measures for understanding and implementing procedures to prevent ill food handlers from working are going to be very different from the process control measures that I briefly highlighted for Salmonella outbreaks. Another tool that we use a lot to highlight these common associations between food, the environment, and the pathogen is this procedures to investigate foodborne illness. It's put out by the International Association of Food Protection. This is a great tool. We use this to highlight these relationships and to drum up the support of the importance of putting together some hypotheses before you step foot into a restaurant, and having somewhat of a plan of what you're going to look at and what you may be dealing with. This tool is just wonderful in looking at some common associations in the farm to fork continuum between pathogen and the environment that they live in and the food handling practices in the firm. So quickly just highlight the table within this book. You can see here we're going to be looking at vegetables, and you have these different environments that are highlighted, farm and field, processing, and then retail store and food service, so restaurants, and then your home. And then under that box, you can see a legend of the different contributing factors that you should consider during these outbreaks, with the red X being a principal contributing factor to consider, and then a green check as a probable factor to consider, and then a purple triangle as a potential factor to consider. So with this one, we're looking at leafy greens and a Salmonella outbreak. So you can see with this diagram, if your suspect vehicle is leafy greens and your suspected or known pathogen is Salmonella, that a good potential contributing factor to consider would be cross-contamination. And then likewise for improper cleaning of equipment, so proper sanitation. That was an example I mentioned earlier. And then we're going to look at norovirus here. So looking at norovirus in the same food commodity, you can see the principal factor to consider is a worker person. So just wanted to quickly highlight this tool to folks if you're trying to generate some hypotheses before you step foot into the restaurant and areas in the restaurant you want to look at. This is a great tool for that. And I think others on this webinar are going to discuss, questions and interviews, but just briefly, I wanted to go over some solid questions asked during a norovirus outbreak investigation. Have any of you or your staff reported being ill? And then some follow-up questions with that. Do you have an ill employee illness policy? Do you maintain sick or call-out logs? Do you have employee work calendar from the past month? This has been a tool we use. A lot of restaurants we deal with don't necessarily have a sick log, but we've been able to look at employee calendars and notice that an employee that usually is there 5 days a week, for some reason 1 week they didn't work for a couple of days, and that might narrow down a potential ill food handler. And then another thing I wanted to point out too is that a lot of times etiology can be difficult to determine during norovirus outbreaks. And if you're doing that assessment and you do identify ill food handlers, just being prepared and have the tools you need to provide them with a stool kit and try to get stools so you can pin down and confirm the outbreak. This is extremely beneficial to the entire outbreak team to try to get that stool and find the exact bug that you're dealing with. Another great follow-up question, if no one's reporting illness, asking if other family members have had vomiting or diarrheal events or have been sick at home. We've worked an outbreak in 2018 where none of the employees were reporting illness, but when we asked this question, we identified the primary food handler on the day of exposure had a child that was having vomiting and diarrheal events, and they were changing their diapers and involved in cleaning up after them. And we determined that this was likely how the virus got into the facility. So that's another great kind of deeper follow-up question to ask. Some other questions to consider during noro outbreaks. Was there any vomiting or diarrheal events in the restaurant? It's happened with us in our outbreak investigations before, where we had a child throw up at a table. The manager then proceeded to clean up after that, and subsequently went and handled some dessert bars, and then did a bunch of other activities in the firm. And our hypotheses, after doing a number of different analytics, spatial analytics, and time analytics on that outbreak investigation, that it was multimodal and likely transmitted by improper cleaning in the establishment and not properly washing your hands after cleaning up. And we're actually about a week after that particular outbreak able to identify a positive noro swab from the table the child reportedly threw up at. And that brings us to environmental sampling. I think this is kind of a novel a tool. We actually, one of our SNET studies, our single site studies, was to try to launch environmental sampling for norovirus and see if that would be a powerful tool in our outbreak investigation. But it's definitely something you should consider or look into. It's helped us immensely on a couple of outbreaks, some where we were unable to get stool and confirm the pathogen, and in other outbreaks just providing another layer of evidence to support how and why the outbreak occurred, which really helps to reemphasize our control measures that we put into place. And then sewage questions are always good to ask if there's been any backups in the floor drains or if the toilets have had issues with overflowing. That could be a possible route that the virus got into the facility. There's a number of things during the EA that are helpful for seeing if there's just poor food handling culture in the facility, a poor hand washing culture, and looking at do they practice no bare hand contact with ready-to-eat foods like we can see in the picture here? Is proper hand washing observed, and how are the facilities, the hand washing facilities, are they all stocked up, properly maintained, and not blocked? I talked a lot about ill food handlers here, but just wanted to highlight again, like I did earlier, that there are norovirus outbreaks that are source related. And historically, we've seen raw oyster outbreaks and some frozen berry outbreaks. These investigations, you are likely going to get a food signal and will not just be isolated to that point of service, but likely involve multiple restaurants in multiple jurisdictions. And this outbreak type is going to have a very different approach to it and different control measures. And likely our federal partners will be heavily involved in these with traceback investigations. So quickly, just an outbreak example I wanted to highlight here. We received a complaint. This was back in January of 2019. The ill people reported a meal date of 126, and that 5 out of their 20 in their dining party were ill. They were all reporting about a 30 to 40 hour incubation and having diarrheal and vomiting symptoms. And luckily, they were all resolving in 1 to 2 days. So, we're in the middle of norovirus season. This definitely perked our ears, and we were all thinking this was likely a norovirus outbreak from the onset, just from the initial interviews. A environmental assessment was conducted on the 30th. We did identify ill food handlers during this investigation. We had 3 employees that reported not feeling well. They weren't at that location at the time and actually worked at multiple locations in the Middle Tennessee area. Same restaurant chain had two different restaurants. They did not have a written illness policy. It was verbal and did not address any exclusion or restriction policies. Also during the assessment, we identified improper hand washing and improper glove use with an employee wearing 3 layers of gloves and peeling those off in substitution of a hand wash. And we saw the same employee eating on the cook line, carrying a chocolate bar with their teeth and then consuming it when we asked them to not eat on the line and that they need to go wash their hands before they handled food. They went to the hand sink and then washed their hands with their gloves on. So just from those basic observations, and that was really right at the beginning of the assessment, we knew that there were some issues with their hand washing culture there. They also did not have any type of policy, disinfection policy for cleaning up vomiting or diarrheal events. We collected NIRS data during this first site visit, and we're able to put in immediate control measures. Again, we don't know for sure if the outbreak happened here, but with the reports of illness and based off of what we saw, we provided them with a written illness policy example and discussed proper hand washing with the entire staff, and then also went ahead and had them do some proper disinfection on food contact surfaces and touch points throughout the restaurant to try to eliminate the pathogen if it was there. During this time, we started getting stool back from some of our cases, and norovirus was confirmed in these cases. We were able to conduct a second site visit, and were able to track down the 3 ill employees. This took a little bit of work because they were at multiple locations, but we were actually able to interview them at their second location and provide stool specimens. And we went ahead and decided to collect some swabs throughout the kitchen and the restroom areas and continue to share some more education documents with them, specifically dealing with norovirus. Our clinical lab results, you can see here, these are all of our cases that are circled. We had 5 G2 positives, and then we also, of the 3 employees, 2 of them were G2 positive for norovirus, and the 3rd ill employee was negative. We were a little surprised by this because we weren't able to get their stool until over 2 weeks had passed from their illness onset. They had fully recovered, weren't exhibiting any symptoms at the time we were able to collect the stool, but still they were shedding, viral particles from their illness, and we were still able to detect it. And just wanted to highlight this because I know that these debates have come up in our own investigation team, and I've heard from other sites that are hesitant to collect stool specimen after the individual's symptoms have resolved, but being able to get these employee stool positives was just again, just great information for our team in supporting that, the restaurant hypotheses and the food handler hypotheses and reinforcing those control measures. We did collect 17 swabs, like I said, all throughout the restaurant. We did identify 2 positive swabs. Both of them were underneath the toilet seat in the men's and women's restroom. There's a lot of noro circulating in the community at the time. You got to take these results with a little bit of, with some caveats. One being that a restroom's is kind of ground zero for norovirus shedding, and these viruses could have come from, customers or other folks in the restaurant, not necessarily the ill employees. But again, us being able to go to the restaurant and go, look, we identified norovirus in your restaurant, that really, I think, helped bring things to light for them and reinforce why the control measures we were discussing, the employee illness restrictions, and the proper disinfection and proper hygienic practices are so important to keep this virus out of your facility. And they were shocked to know that they had virus there in their restaurant that we were able to detect. So kind of bringing it all back to control measures, in the outbreak example I just discussed with you, control measures we put into place were, first of all, they more increased inspection frequency, which happens with any restaurant that we have that has a confirmed outbreak, and obviously reinforcing the illness policy, getting a written policy in place in both English and Spanish, and ensuring that the owners are aware of the importance of having such a policy. We did not see any no bare hand contact, but obviously identified some hand washing issues and that they didn't have a proper disinfectant to denature norovirus in their facility. So those were some of the control measures we put in place there. Looking at source related or sewage related outbreak, obviously maintenance and determining food source, ensuring foods are coming from approved sources would all be good control measures for those types of noro outbreaks. just wanted to highlight here real quick some of the great resources that are out there. The Centers of Excellence offers a whole suite of tools from, I know Cornell's been doing a bunch of work on interviewing. We do a lot of Epi-Ready trainings, and there's just a whole plethora of information out there. And Tennessee has some good environmental assessment trainings on their COE page. And then the CDC Environmental Assessment Training Series site is back up and running. This is a wonderful tool to get inspectors in the mindset of the differences between conducting an outbreak investigation versus performing routine inspections, and really gets them in that kind of investigator detective mindsets, and gives them some great tools and training to conduct environmental assessments. And then AFTO over the past couple of years has launched an environmental sampling training. So wanted to let you know that's out there, that environmental sampling training is in person. Not sure when that's going to get ramped up again, but I expect it to come up and running again here soon. And I just wanted to thank all of the great people on my team. These outbreaks are extremely complex and require folks with an array of expertise, and it takes all of these folks and all the folks I didn't mention to be able to pull off these investigations and the studies and the other activities that we do. So thank you to all of these people, and I'll leave it there.
Okay, DJ, if you stop sharing your screen, then I can share mine.
Yes, sir.
Thank you. Okay, if I can have a quick verbal that everyone can see my screen.
Yes.
Okay, so I'm going to bring us home, and I'm going to go pretty quickly through these slides, just give an opportunity for some questions. I did share the slides in the chat box, and if anyone has problems accessing them, you can email me afterwards. As DJ mentioned, I'm also part of the Integrated Food Safety Centers of Excellence, which is a great resource. I'm not going to belabor that, as you already mentioned it. I'm going to go through three things today. Beth already covered the importance of environmental assessments. So I'm going to just skip over this and then talk about the interview process. One important thing for the environmental assessment is, if you have experienced investigators going out, they may remember the difference between contributing factors and environmental antecedents. If you send out people that don't do this regularly, it might be great to sort of have them review that so they're in the right mindset before they go out on the interview. So how do you prepare for the interview? Importantly, one thing is to make sure that people who go out understand that this is not an inspection. Sometimes people who get out for these environmental assessments are more used to inspection. And we're not looking for regulatory issues, even though regulatory issues can sometimes be contributing factors or environmental antecedents, but we're looking really for what contributed to this outbreak or the cases that we see. Before you go, make sure you review the relevant reporting sections, make sure what you have to fill out at the end, make sure you have the appropriate forms ready, and review the complaints and any available EPI information. And where possible, maybe even quickly meet with EPI or lab personnel to discuss the outbreak, figure out a plan. And sometimes that might give you important information, even whether you're looking at a person-to-person transmission event or maybe even a food event. When you have a standard interview form, make sure you understand the questions and review them and schedule enough time for the interview so you don't get rushed at the end. A priori, understand what you're working with. Is this a single fine dining institution? Is it a chain restaurant? If it's a chain restaurant, you might have issues in multiple facilities that could be sharing employees and other things. Review all of this, be prepared so that you don't need to collect some of that information necessary when you're there for the interview. Understand the pathogen. We had some good introduction to that. And why is that so important is because you're not doing a cookie cutter interview or observations. With norovirus, cooling of food, probably not high priority, not high priority, unless you would say that improper cooling indicates poor food safety culture. So make sure the investigators and people who go out do not waste their time with looking at things that are not relevant to norovirus when you go out to investigate a norovirus outbreak. Make sure you remind yourself what the typical sources are. You know, with norovirus, some people go out might just think about sick workers or maybe sick patrons. We heard about other food sources that they can play a role. Oysters, mussels, even produce and fruits. If that becomes the major issue, make sure you're prepared to do a traceback investigation to identify those sources. So let's talk about conducting the interview. You'll interview managers and employees. Make sure if you have specific policies on interviewing food workers, what you should do if you have specific forms to use. This is maybe the one thing to really remember. The interview is actually only part of it. And some experienced individuals saying 50% of the interview isn't the actual interview. It's you being there and observing people, watching people while you're talking to people. I had this happen to myself. I was in a facility for interviewing people and then sort of just sat in the waiting room, and I overheard someone come out into the waiting room to the receptionist. It was a food processing facility, and said, "We need to send someone out to get some Imodium." And I was just like stopped in my track. I'm like, Imodium? Why would you bring Imodium in a food processing facility? Obviously, clearly showing that the sick policies, if they were in place, didn't work. Now that's an extreme example. But sometimes by just listening and being sort of a fly on the wall, you can get some very important information that you may not get out of people when you ask them. So introduce yourself, explain why you're here. Try to not make it like a third degree investigation, but remain conversational. Try to get information out, make people feel comfortable with you so you can get at some of the key questions and get some of the key answers that are not always easy to get, as we mentioned before. You want to see the facility operate under normal circumstances. Ideally you walk in, observe what's going on before you talk, and then maybe even after you're done, hang around a little bit, see what happens after you left. Often the before and after can get you important insights. Even though it's not necessarily the specific interview, it's still a very, very important part of the visit. Interview managers, there are resources to use for this. We went through a lot of them, questions about the establishment, glove policies, obviously, question about kitchen managers. We talked about the importance of managers receiving food safety training, what sort of food safety training is provided. Even if things are, in the model food code, remember, not every state adopts the same or the current version of the model food code. Very important to figure out what policies are actually followed in a specific state or in a specific establishment. Questions about food workers. Often language can be a barrier. Make sure you check on that. Make sure the training is in the appropriate language and can be understood by the food workers. Cleaning policies. We talked about it. Does the establishment have a policy for cleanup after an incident? When was the last incident? Were those policies followed? All of those are key questions to ask the food manager. Temperature policies, maybe in your standard questionnaire for norovirus, I'd probably skip over those. Questions about employee health policies. We talked a lot about the importance of the idea that paid sick leave is very important. Now you have to go above and beyond it. What we might see more and more is that companies have paid sick leave or establishments, but to pay a premium if you show up. So therefore, sort of almost like counteracting the positive effect of a paid sick leave. Because if you get a bonus of a few $100s for showing up, for not missing a day of work in 3 months, you may be incentivized to go to work even though you are sick. So dig a little bit deeper in there sometimes, try to figure out what is really happening, and some incentives that might be at place that might still lead to people that are ill showing up at work and working. Here's some of the specific from NIRS on it. Everyone here can read faster than I can. So next, let's move to worker interviews. Choose the right worker or workers. That can be based on the information with EPI. who worked on a day of exposure, who prepared food on that day. Always try to interview the workers separately from the managers, somewhere in private, because having the manager even able to be overhear what the worker said might make it very, very difficult to extract information from the worker. With the worker, even, the managers often know why you're here. With the workers, it's even more important to stay calm, relaxed, and just try to get them to sort of open up to you. You will generally ask work questions similar to what you asked the manager. Partially to check with a disconnect between what you hear from the manager and what you hear from the employee. Part of it to check whether the workers actually know and follow the policies. Are they really trained the way the manager says? If there's a language barrier, do they really understand the training? Do they really understand the sick policies? Even if the policy officially is, to give people paid or unpaid sick leave, do they really feel they can comply with it? Is there fear of retaliation if they don't show up? Or is there a bonus structure or premium if you have a certain amount of days where you don't call in sick? All of this could contribute to sick people showing up and contributing to an outbreak. Ask more direct questions about the investigation. If you have a suspect food vehicle, specifically ask about how the product was prepared. In this case, we might not have to ask about cooling, but it's not inconceivable that you might have undercooked shellfish or so that could contribute to it. So in these specific cases, you might have to dig into cooking temperature and preparation practices. Obviously, any practices that can lead to cross-contamination, extremely important. Glove wearing, separate utensils, we talked all about that. Part of this is going to be interview, but again, part of this is really watching while you interview workers to see what do the people really do while you're there interviewing the person. Obviously, essentially determine whether any workers have been sick. May mean you interview a considerable number of workers. We talked about asking questions about illness of family members, specifically probe for the symptoms, and be very aware of that. People might be very hesitant to tell you that they came to work sick, particularly if they know that there is a company sick policy. Make sure they know there is confidentiality. Make sure that the workers feel safe by saying, sometimes you could become sick as part of an outbreak, implying that it's not you who made a mistake, but you were sort of on the receiving end. Anything you can to have workers open up to you to give you information can and would be very important. Post-interview, when you're done with the interview, it doesn't mean, you're done, as I mentioned before. Stick around, see what's going on, see what the people do, what they told you to do. Note taking, obviously a great idea, but if you start taking notes right from the get-go, people will, not as easily open up to you. Again, try to be friendly and make it feel less threatening, which it will be in many cases. Exit interview, we talked about it. Obviously, after you're done, discuss your findings, see whether there's any immediate steps they can take to prevent further cases or prevent future outbreaks associated with the facility or the product, if it's a product. So with that, I hope we sort of wrapped up what you heard already a few times. With Noro in particular, interviews with managers and employees are vital. Collecting this information is essential as Beth said to drive long-term policy changes, etc., that will really reduce norovirus transmission. And the one thing I want to leave you with, interview, you might think you're doing an interview, but as that 50% of being successful, there might not be as much the questions you ask, but the observations you make while everyone else thinks you're just talking to someone. These observations can be really, really important to find out what's going on and what might have happened here. So with that, I hopefully have given you some useful information and given us a few minutes for questions. Thank you.
Thank you so much. If we can have all of our presenters turn your cameras back on. We do just have a couple minutes and we've gotten a lot of questions. I don't know how many we'll be able to get through. One that ties back to DJ's presentation, we got the question, if a stool sample from an employee or a customer is submitted to the lab for analysis and that could take days to come back, how should the investigation team work? Should they wait for those results that could take days, or how can they overcompensate for the timeline as they're waiting for those results?
Yeah, I mean, like I mentioned earlier, we do not wait to implement control measures if or based off of clinical results. If we have a strong signal in a facility and a symptom profile and we're finding deviations that could lead to that outbreak, even if it's suspected at that point, we're going to go ahead and initiate immediate control measures regardless. Now, those control measures will get more and more refined and maybe get more specific as more outbreak data comes in from our epi and lab teams, but we're not necessarily going to wait for all of that information to get in good food safety handling practices in the firm.
Thanks. We also had a question that in hospitals, there is an infection prevention team that goes around monitoring hand hygiene and other infection prevention practices. How can a restaurant manager monitor and check if their employees are following good hand hygiene, not coming to work if they're ill? Is there anything like this that has been implemented in any restaurants that you all are aware of? And I'll just open it. This came up during Beth's presentation, but I just wanted to see if Beth wanted to start and if anyone else has anything to add.
Sure. I wanted to state that I love the comparison between IPC and healthcare settings, because I think we can learn a lot from what they've done, and they've also are masters in root cause analysis. So I really want to give that question to DJ as he is in the field. So I'll give it to him.
Well, I'll give you a story. I had a wonderful manager that I worked for when I was in the restaurant business, just an extremely effective general manager. And one of the things that he would do is on a Friday night, our busiest shift, he would stand by the hand sink in the dish area where servers and people are coming in to throw plates off, obviously handling people's plates after they'd eat them, and he stood by the hand sink by the dish area, and he wouldn't let anybody walk out of that area without a proper hand wash. So I think, that's just one example, but it really highlights the importance of active managerial control on the firm. And hand washing is not I'm going to talk to you about it, and hope you guys do it. It is something that has to be, from a managerial perspective, it's got to be something you're looking for and calling out and emphasizing on a daily basis. Hope that helps.
Maybe quickly add to it, I think what we're talking about is really food safety culture, which we typically talk more about in the processing side. And I think some retailers, some QSRs definitely working towards that. And as DJ mentioned, as management, just looking at it, reinforcing it, leading by example. Often management does not. I think that's the other really important thing. They come in sick and with the sniffles and it's I'm so important, but the example they set is it's okay to come in sick. And sometimes people don't think through that. So I think that's also really, really important. But so food safety culture, definitely important. I think in the long term, trying to capture that in interviews or these investigations, what the food safety culture is going to be very important.
So I don't know if you would have anything, this kind of ties into another question that we got, and I don't know if you would have anything to add to this. Somebody asked to the CDC or FDA or USDA about studies of jurisdictions that require food handler training, and if that has resulted in the lower incidence of foodborne illness. And they mentioned, there are some jurisdictions that do have mandatory sick leave available for mid to large scale employers. And are there any studies that show whether the sick leave availability results in a lower incidence of foodborne illness? And is there anything being done nationally to mandate sick leave for workers in food facilities? I'll just throw it out to you. If anybody has anything to add, we all know as you were talking about it, I thought, man, I've been hearing about this for years, that mandated sick leave would help so much.
So I can start it off and then pass it on to the other panelists. So there is one study that showed lower foodborne illness rates, so I can post it in the chat. And that was with the mandated paid sick leave laws. One of our ESNet sites is also looking at this in terms of foodborne rates with norovirus in restaurants. And as they mandate sick leave for certain businesses as they meet the criteria. In terms of CDCR stances, we definitely, recommend paid sick leave if as we think that will help prevent people coming in while sick, but that's not the only thing. As some of the research I've showed, people come into work while sick for many other reasons. And in terms of who's doing that, it would be people not with the federal government, but lobbying. So consumer safety folks and other folks will be doing that. And then there was another question about required food handler training. And if that has resulted in a lower incidence of foodborne illness. I'll also post a study that we've conducted showing if you have food worker training, it will result in smaller and shorter norovirus outbreaks. So I can show you that, and the type of training also makes a difference. So other panelists, please chime in.
If you want, or no pressure if you don't have anything to add, because I see we are coming up on the end of our webinar time, and we did have many questions that we were not able to answer. So we might see if maybe we can send a follow-up email with some answers to some of these additional questions if we can, or we'll see if we can connect you back to the speakers. If you have questions, you got their contact information from their presentations. And we appreciate everyone joining us this afternoon or this morning, depending on where you are, to participate. And a big round of virtual applause for our amazing presenters for sharing all this information. As you can see, there's a lot of positive feedback and a lot of great interaction in the chat throughout the webinar today. So thank you all so much for your overview and for your information that you shared with everyone.